Hello, I'm Dr. Brian Cole from Rush University Medical Center, Midwest Orthopedics in Chicago, and welcome to this virtual educational experience. My talk over the next few minutes will be discussing the clinical application of orthobiologics as it relates to rotator cuff repair augmentation. I have nothing specific to disclose to the topic, however, all of my disclosures are available at the AAOS website. Clearly, rotator cuff pathology is still one of the most common causes of shoulder pain in individuals over the age of 50. And what's interesting is that they are largely attritional in etiology. While they may show up as a traumatic experience, the vast majority of what we're seeing in our offices today relate to failure over time from attritional and degenerative processes, really suggesting inherently bad biology. The good news is when patients do present and we treat them, clinical outcomes, either when we treat them non-surgically or surgically, are actually quite good. But we still see, despite some of the best treatments biomechanically, failure of the structural integrity at the level of the insertion where bone is to grow into tendon. Much of this problem of integrity of the tendon and follow-up is related to the really unique biologic challenges that the rotator cuff tendon has as it relates to bone at the insertion and enthesis. And all of these factors that you see here in this slide are particularly relevant. There's a great book by Atul Gawande called Being Mortal, where he says, our bodies are sort of rotting from the inside out as we age. And I think that's particularly true as it relates to the tendon of the rotator cuff unit. We specifically looked at this factor, and this is some work that we've collaborated on with Colorado State, specifically Dr. Sykes and Dr. Frisbee and others. And we looked at retrieval specimens for metabolomics analysis from those undergoing total shoulder arthroplasty where the rotator cuff was intact and presumably normal, those who had chronic rotator cuff tears who were undergoing reverse shoulder arthroplasty, and those who had rotator cuff repair with maybe subacute or acute on chronic changes. And what's really interesting is that there's a significant difference of protein and metabolomics across these different categories, but the distinctions weren't really related to age or sex or diabetes or the duration of symptoms or the time for the diagnosis. But what we did see is that acute tears or acute on chronic tears were potentially associated with cell death and decreased metabolic activity. So we're using this model in the human rotator cuff to say, how can we actually intervene biologically to reverse or interfere with this process that inexorably progresses over time as we age? The question that commonly comes up is, look, we tend to do well clinically, and does it really matter if the rotator cuff is not intact? And I would say that if you carefully look at the literature, it suggests that patients with a healed rotator cuff have greater strength and greater satisfaction. The big challenge is that when we look at strength, for example, as a surrogate for function, one of the issues is that we don't measure it with any great significance in terms of what it contributes to the outcome scores. For example, the constant score is roughly 25 points out of 100, and it's not often corrected by age and gender. So we probably don't do a great job of capturing objective function in our current outcome scores, but if you just look at patient function and return, generally speaking, when the cuff is intact, patients do have greater strength and greater satisfaction. What we're trying to achieve is this enthesis regeneration. We'd love to have that mineralized fibrocartilage layer as the tendon goes into bone. But what we get often is reactive scar or scar incontinuity and failure to develop the mineralized fibrocartilage aspect of the insertion site. And a lot of this happens because we just heal by fibrosis, and it's an inflammatory process where we see fibrosis rather than true tissue regeneration. So then it begs the question, can we actually improve the tendon-bone interface? And there's essentially two pathways to do this. One of them are the use of scaffolds, which perhaps enhance material properties. And the other is to use biologics that may enhance the structural properties as you see here. But all these principles really embody the concept of tissue engineering to potentially regenerate the tendon or the bone-tendon interface. And if you wanted to sort of create the holy grail, we'd love to have progenitor cells, we'd like to have growth factors, we'd like to have a scaffold to keep things in place, and we'd like to have angiogenesis to improve blood flow and blood supply to the local area. But we really have limited options. For one, we know from a biologic augmentation point of view, the role of PRP and bone marrow aspirate has been described, and we'll review that. It's interesting when you look at the basic science of PRP and rotator cuff disease, that what we found in culture is that leukocyte-poor PRP may actually promote collagen synthesis in diseased tendon and decrease catabolic cytokines versus leukocyte-rich PRP when we're analyzing this in culture. There's some other important roles, however, for PRP. They actually may signal for MSCs, and that's been shown by a number of authors. In addition to promoting mitosis and migration of the host MSCs into the area. Now, we looked at sort of some basic models, sort of the poor man's PRP. And if you look at some of the literature in this area, it's interesting that simply performing marrow stimulation may actually have a benefit in rotator cuff healing. And that's designed to provide access to MSCs that are inherently present endogenously in our bone. When we look at the literature and try to summarize the effects of PRP and rotator cuff healing, there's some data that suggests when it's applied at the tendon bone interface, especially for double row repairs and even small and medium tears, that they may improve with the use of PRP, but not when fibrin was actually present. So I think we have a general feeling that there's absolutely no downside other than the potential cost for the use of PRP and rotator cuff repair. And there are a few studies, level 1 in Nature, that have shown that PRP presence actually enhances healing rates. There have been some alternative uses of PRP in the setting of rotator cuff tears and repair. This one study looked at the interstitial application of leukocyte-rich PRP versus saline in partial thickness tears, and it did not lead to the healing of partial thickness rotator cuff tears. I'll show you another study soon with the use of MSCs or bone marrow concentrate, I think, where they actually did show a difference. In addition, the use of PRP after rotator cuff repair has been of interest, and there was no change in function when leukocyte-rich PRP was used after rotator cuff repair. So I think the general take home is that there may be some clinical benefit in terms of integrity when PRP is used in the setting of small to medium-sized tears, especially to enhance double row repair. So what about connective tissue progenitor cells? We are trying to get away from the terminology of stem cells. While the cells we're able to obtain in bone marrow or adipose, for example, may have stemness or stem characteristics in vitro, truth be told, the way they're being used in vivo in the clinical setting that we customarily use them, probably they function more with a paracrine effect or upregulating the local environment. They may, again, cause migration or an uptick in activity in endogenous MSCs. So they may recruit other MSCs, and they probably secrete bioactive growth factors that promote all of these things, such as angiogenesis and mitosis. And they probably act most in local modulation by reducing inflammation and having a positive impact on the immune system. The question is, are they really clinically relevant? One of the first studies was published by Hernigau that looked at patients to see what the differences in patients who had a rotator cuff tear versus those that did not. And with the finding here, and again, it begs the question, is it the chicken or the egg? But patients without a rotator cuff tear had more MSCs present at the local tendon bone interface than those with a rotator cuff tear. We've also looked at gene expression of progenitor cells isolated from rat rotator cuff muscle tendon unit. And when we cultured these from the muscle tendon unit, we identified similar progenitor cells within the and gene expression at the tendon and the muscle tendon junction. So the concept here is that there may be a role for the use of rotator cuff progenitor cells from the muscle tendon junction as an alternative to treat diseased tendon. This is the subject of ongoing research. There's some other models that have looked at the use of bone marrow-derived MSCs in rat rotator cuff repair. And this one looked at it in a fibrin carrier and showed that cells alone did not improve healing. And it really, I think, suggests that it may not only be cells, but we have to be thinking more globally. The provision of growth factors, cells, a scaffold, all of which may promote angiogenesis. That may be where we're heading, rather than just assuming that we can just inject cell-based sources of growth factors and hope that they actually make a significant difference. That being said, there is actually some literature looking at the outcomes of bone marrow concentrate and adipose. The study that's most often quoted is Hernigau's work, where it was a matched control case study looking at 45 patients who had bone marrow concentrate injected versus 45 who did not at the time of rotator cuff repair. And these were patients who had bone marrow concentrate obtained from the ASIS. And they showed a pretty profound difference at 10 years in terms of tendon integrity, as you see here. There's another study that was level 3 using matched groups looking at MRI for structural integrity with the use of adipose tissue that also showed the integrity to be greater when adipose tissue was present. I'll share with you some preliminary results that have been presented on the podium. The use of bone marrow concentrate in a transosseous equivalent repair for a single supraspinatus tendon tear that was performed at our institution in collaboration with these co-authors. And our provisional results showed that we had a significant and strong association between the presence of bone marrow concentrate and a lower SIGAIA score at 1 year. So just to help understand what that means is that when we use this scoring system you see on the bottom right, described by SIGAIA, we had about a 1-point difference in favor of the use of bone marrow concentrate looking at 1 year, reflecting the anatomic integrity of the tendon. Now there's some other options. I told you before that when others looked at the role of PRP to affect interstitial changes that you might see on MRI, and there was no difference. There was actually a difference in this study that looked at the use of MSCs injected intratendinously. But keep in mind, these were cultured, not something that we can do now. That would be sort of like using a drug. This would have to be either through an IDE or some type of exemption performed in a university or academic setting. But these would be autologous cultured MSCs from adipose and partial thickness rotator cuff tears, and the MRI showed resolved bursal-sided defects. So that was of particular interest. But again, that's cultured, which has a whole different paradigm compared to simply concentrating MSCs. Below is an area that is a subject of research that many of us have become quite interested in, and it's the use of a receptacle that's placed in line with the shaver that can capture the bursa. And there's some suggestion that through isolation and characterization of bursal tissue, there are MSCs and maybe provide healing factors that might improve tendon bone healing. So this is the subject of ongoing research, and it's of particular interest because it's a low-cost solution that could be point of care. And you could do this today, but we're still looking at research to actually support its intent. There's some other interesting biologic factors that suggest that scaffolds such as demineralized bone placed at the tendon bone interface might improve histology, MRI, and biomechanics, as you've seen in some of these studies. And I think that's another interesting way to look at it, because really the pathology exists at the tendon bone interface, and that's where we have some of the biggest challenges as we age, because we're seeing changes at the bone, we're seeing changes in the tendon, and if that process can be enhanced, such as with the use of demineralized bone matrix, or maybe bone matrix as a carrier scaffold that can be conductive and inductive at the same time, may actually prove to have a difference. So in conclusion, what I provided you is a basic overview of the use of orthobiologics. I purposely left out the use of scaffolds because we know that, for example, the use of dermal grafts has either as an extension or interposition through a number of level 1 studies is actually shown to have significant benefit. What I've highlighted, however, is the use of orthobiologics to enhance the environment at the time of rotator cuff repair, absent of a scaffold. Rotator cuff tears are associated with poor tendon biology and are largely degenerative in nature. Essentially, rotator cuff tears heal with scar and continuity and have poor material properties, even if we can improve the structural properties. So it makes sense that if we can use growth factors as well as other things like cells and scaffolds, that we may be able to make a difference. But we probably need pluripotent cells that are either signaled for because of something we apply, and then subsequently licensed to recapitulate the emphasis development. I know that's a lot of words. The bottom line is we're just trying to improve the emphasis or the tendon bone healing environment, which is faulty because of what happens over time through this degenerative process that we see as we age. There's clearly some accumulating evidence in favor of PRP and bone marrow concentrate. If you say, well, what do you do? What I do is, if we have a discussion, because these are both PRP and bone marrow concentrate are not covered by insurance, so it's not a pocket expense. And I think the argument is that we see no downside from a biologic or adverse event point of view. There is an economic impact, obviously, of using either one of these to both the facility, basically on the facility side for capital equipment and so forth. So you have to have a cogent discussion with patients, and I think staying away from the words regeneration necessarily, or stem cells and so forth, and discussing the fact that there's some early evidence that might support the use of application of growth factors locally to improve outcomes in tendon healing. And the evidence, I think, does exist both with PRP and bone marrow concentrate, but I'm not certain we're ready to say it's a dominant treatment strategy. So if money didn't matter, I would argue that this is probably a good strategy now, even in the absence of perfect data. But it really is incumbent upon us to get that data as perfect as possible, especially given the economic factors. And we're weighing that against the cost of revision, obviously. So I think there is an argument to be made, but we obviously, like many of these things, need more research. But I would say in the next 3 to 5 years, I think we're going to have it. And because there's a number of sites that are actually doing very good research, getting rid of some of the heterogeneity in these populations to show that it can make a difference. But in the end, I think it's going to be much more than just applying sort of a liquid of growth factors. It's going to require cells and signals and scaffolds. And I think that's how we're ultimately going to attack that otherwise irreversible process to lead to a durable rotator cuff repair. So I want to thank you for your time and attention, and for attending this virtual educational experience. And I wish you wellness and safety moving forward. Thank you.